for the kind introduction. And so for the sake of our international guests, I'm going to speak in English, but if you guys have any questions afterwards, you can even do it in Portuguese, there's no problem. For those who have seen my previous presentation at this meeting, you're going to see that today I brought something very different from what I spoke before, and that is something that we are developing very recently at the Brazilian National Cancer Institute, INCA. So I'm going to talk about HIV infection and cancer outcomes in Brazil, and particularly in the Brazilian Cancer Institute in Rio de Janeiro, and a possible role of the immune surveillance on those outcomes. So the association of certain types of cancer with HIV infection goes back to the beginning of the AIDS epidemic. So for those of you who read about, the students probably read about the history of HIV and AIDS, know that the first indications of a novel disease in the beginning of the 80s that called the attention of clinicians in New York and San Francisco actually were some sort of rare diseases affecting men who had sex with men, young men who had sex with men in those places. And among those diseases was a very rare type of cancer, which we call Kaposi sarcoma. So it is all known since the beginning of the AIDS epidemic, certain relationships with HIV infection. So at the point that early in the epidemic, there was a clinical definition of certain types of cancer that would actually define the stage of AIDS in HIV-infected people. And so these were referred to as AIDS-defining cancers. These cancers were generally related to immune suppression, so that's why we see in people with AIDS at that time, and we see even today if the person is severely immunosuppressed. And also, these AIDS-defining cancers are mostly related to infection by certain opportunistic viruses. So you'll see Kaposi sarcoma, which we now know it's an infection, becomes as an infection with a herpes virus, non-Hodgkin's lymphoma, which is usually associated with Epstein-Barr virus, and cervical cancer, usually and certainly always associated with human papillomavirus or HPV. So since the introduction of the highly active antiretroviral therapy in 1996 worldwide, and in the US and here in Brazil as well, this has changed the epidemic trends of cancers in the HIV-positive population. So because of HEART, the control of HIV viral load was done to undetectable levels for the first time, and we had patients with partial or almost very good reestablishment of immune competence, and of course an increase in overall life expectancy. So now HIV-infected patients would live longer and would be susceptible to other types of malignancies that are also found commonly in older people, HIV in general population, HIV uninfected people. So this is what we call AIDS or non-AIDS defining cancers that arise after the HEART introduction as an important morbidity and mortality factor in the HIV positive population. So there was this shift in trends in this population from AIDS-defining to non-AIDS-defining cancers. So non-AIDS-defining cancers in principle, and that's because they also occur in the general population, which is primarily immunocompetent. So in principle, people would suspect that non-AIDS-defining cancers are not directly related to immune suppression. But actually what I'm going to try to convince you today is that that is not necessarily the case. I mean, immune suppression plays an important role for all types of cancer, including non-AIDS defining cancers. And I just listed a few of them here: Hodgkin's lymphoma, lung cancer, liver cancer, anal cancer, breast cancer, and many others that are not listed right here. So, so this shift in trends of cancer cases among HIV-infected people was really unveiled after some important studies and actions in the United States where cancer and HIV/AIDS registries have been combined to evaluate cancer burden and epidemiological trends in this population, as well as the effect of HIV infection in those burdens. So this was done by linking state cancer registries, which are centralized at the National Cancer Institute in the US, with the HIV/AIDS state registries, which are, of course, centralized in the Centers for Disease Control and Prevention in Atlanta. So one of these initiatives that really combine these registries is called HIV/AIDS Match Study, and this is exactly what the investigators did by combining these two kinds of registries. And this is a big project which is financed by the U.S. NCI, the National Cancer Institute. And as you can see, basically what they do is taking, from different states, and of course there are, as anywhere else in the world, there are states which have very, very good population-based cancer registries and HIV registries, and other states that don't have that well organized. So, but here, the HIV/AIDS Cancer Match Study started, I think, with 14 different states throughout the United States, where they got the data, of course, anonymized data from subjects with AIDS and with HIV, but not AIDS, from all these states, and combined to their HIV registries centralized at the CDC. And some of these issues became really apparent when we do that. So this is one of the papers published by this study, and as we can see here, so this is the number of people in the U.S. Actually with AIDS, okay? And as you can see here, throughout the years, of course, there is an increase in cancer, in the number of cancer cases among this population, and an increase which is also more pronounced in certain age range. For example, here in blue, you have the 40 to 49 years old, and the one in magenta is 50 to 59 years old, and you see an increase in the cancer cases among this population at this age range. Here in this other graph, you see the number of AIDS-defining cancers, and that's really impressive decrease in the prevalence of these and in the number of AIDS defining cancers in the HIV-positive population across the years, particularly after 1996 with the introduction of HAART. So you can see here, the crude number of cases, and the trend line is the incidence per 100,000 people. And as you can see here, AIDS-defining cancers have really dropped down, particularly in this age range of 30 to 39 years old and 40 to 49 years old. When we look now at the non-AIDS defining cancers, you don't see the same picture. You basically see that there is actually an increase, a striking increase in non-AIDS defining cancer in this population. And again, particularly in the 40 to 49 years old and 50 to 59 years old over time. So, of course, We think these people now live longer and are less immunosuppressed. So you don't see those age-defining malignancies, but you see a lot of non-age-defining cancer in this population. And here you can see both types of cancer, age-defining cancers in green and non-age-defining cancers in blue. And as you can see, while one drops across the years, the other one increases across the years. So that's really an epidemiological shift in the trends of these different types of cancer. However, despite this nice study showing these trends, few data are available on the association of HIV and specific outcomes after a diagnosis of cancer, especially in developing countries. So this is true actually for both developed countries, where most of these registers come from national databases, and you don't have very detailed information as to the follow-up of the cancer patients after they get diagnosed, and also, of course, in developing countries like in Africa, for example. I mean, you have very bad registries of everything, both registries, which actually are non-existent in most of countries, and also you don't have good follow-up, you don't have good treatment, etc. So the Brazilian National Cancer Institute, INCA, in Rio, hadn't conducted any study in this population so far. So that's what prompted us to start working in this team over there. So we don't know basic things like the socio-demographic profiles of HIV-infected patients diagnosed with cancer over there. And of course, this type of information is necessary because, to know these profiles, the types of cancer which are most commonly found, will provide information for subsidizing prevention and control of cancer in this vulnerable population. And it's really absent data in Brazil so far. So we started looking at, actually we elected a specific cancer type to start working on this issue. And we did our first study with cervical cancer. And of course, there are reasons to choose cervical cancer because cervical cancer is an important problem in Brazil, as you'll be able to see. And INCA has a very good, let's say, setting for following up and treating cervical cancer patients. For those who don't know, INCA is the Brazilian Ministry of Health National Reference Center for developing policies for cancer control, treatment, implementation of new technologies in health related to cancer, doing the novel cancer estimates for the following years. So it's really a direct administration by the Brazilian Ministry of Health. Over the 15 years, INCA has over 140,000 cancer patients registered in their databases and followed up regularly. Gynecological cancers are a strength at INCA, so that's why we started studying with cervical cancer. Actually, INCA has a fully dedicated unit, a full hospital just dedicated to gynecological cancer treatment and care. And another important issue about cervical cancer is that, and that's worldwide, not only in Brazil, is that despite the advent of heart, cervical cancer cases have not dropped over time as sharply as expected or as sharply as seen in other age-defining malignancies. So actually people nowadays have some controversy about the definition of cervical cancer as an age-defining cancer because cases have not dropped down as we would expect after, the introduction of heart, as it happened with Kaposi sarcoma and non-Hodgkin's lymphoma in the HIV-positive population. So Cervical cancer, is a little bit of background here, is caused by human papillomavirus. It's a major cause of morbidity and mortality among women, especially in developing countries like Brazil. And HIV-infected women are more likely than uninfected women to develop cervical HPV infections, including infections by multiple HPV types. They are also less likely to clear HPV, so HPV persists in those women, and they are also more likely to progress through planioplastic stages to cervical cancer than HIV uninfected counterparts. So among the general female population in Brazil, cervical cancer incidence is about 16 per 100,000 women per year, and the corresponding cervical cancer mortality rate in the country is 7 per 100,000 persons per year. So it's a big problem in Brazil. And as you can see here, I'm sorry, this is in Portuguese, but these are the estimates provided by INCA for 2016. So this was made at the end of last year. And as you can see here, the cervical cancer here, colo do útero, we predict about over 16,000 cases of cervical cancer in Brazil for this year. So being the third most common cancer in women in the Brazilian territory. So HIV-infected cancer patients experience elevated overall mortality compared to HIV-uninfected cancer patients. Some of this excess, of course, is due to deaths from AIDS, as you would expect, but an adverse effect specifically on cancer outcomes is biologically plausible if an intact immune system helps control cancer after treatment. So that's our underlying hypothesis. And very few data exists regarding the association between HIV and cancer-specific outcomes following a cancer diagnosis, both in developed and developing countries, and I've already told you that. So this is a study based on these registries in the United States that looked for all-cause mortality and cancer-specific mortality among HIV-positive, or comparing the HIV-positive with HIV-negative individuals. And as you can see here, this HR column is hazard ratio, right, compared to the HIV-uninfected, which is set as 1. So as you see here, for most of the cancer, so you have oral cavity, colorectal, anus, liver. I'm not going to go through this whole table, but for the majority of cancers, you'll see hazard ratios for all-cause mortality and for cancer-specific mortality above 1 in HIV-infected individuals, meaning that they are more prone to, more likely to die either from anything or specifically from their cancer than HIV-uninfected counterparts. So I highlighted here the cervical cancer. So you have like a 2.5 hazard ratio in HIV-infected people. And for all-cause mortality, and 1.7 to 1.2 to 1.4, specifically for death from cervical cancer in this population. So as these numbers have been multiply corrected for a number of things, including cancer staging, which is, of course, directly related to, associated with cancer deaths or overall deaths, we do think that HIV infection per se also plays an additional role in the overall chances of dying from overall deaths or dying specifically for that cancer. So, given the availability of heart, many HIV-infected women diagnosed with cervical cancer will not die from AIDS, as you would expect. So it's important to understand the impact of HIV on these cancer outcomes. So we assessed outcomes among Brazilian women treated for cervical cancer at INCA during this period, 2001, 2013. So the study started in 2014. So we had 14 complete years here. And HIV-infected and uninfected women were closely matched. And this is important This is a really an important advantage of working at a single center where you have standardization of treatment, of care, of follow-up, and also you can match these two groups on the clinical stage in treatment, and data were available on both early and late cancer outcomes. So for the identification of patients and data collection, it's important that you know what's the routine at INCA for following up cervical cancer cases. So upon diagnostic, so this is a little bit background on how these women are being overseen there. Upon diagnostic confirmation of cervical cancer, because INCA confirms all cases in the pathology department when they are diagnosed from outside, so it's really re-diagnosed at INCA, so we are sure about staging and things like that. So patients then are directed to the gynecological oncology service of INCA. It's called Cancer Hospital Number 2. As I told you, a fully dedicated unit for gynecological follow-up. So a complete history and physical examination are performed, and the referring pathology specimens are reviewed, as I told you. Clinicians identify the presence of HIV infection through clinical history, and if needed, obtain HIV serology testing. So clinical staging, the cancer staging of women is determined at INCA according to International Federation of Gynecologic and Obstetric Standard. And on the basis of this staging evaluation, patients are treated according, of course, to international guidelines as well. So women with local stage cancer are typically treated with surgery or radiation plus chemotherapy, and brachytherapy is also administered at some cases. Patients with regional or distant stage cancer, metastases, are treated with radiation plus chemotherapy. So after treatment is completed, patients are followed up in outpatient appointments at INCA, beginning 1 month after surgery or 4 months after brachytherapy, and subsequently appointments are every 6 months during the first 2 years, and then yearly after that up to 5 years of follow-up. So we want to make sure that there are no relapses or recurrences or a new cancer or anything like that. So women, even when disease-free, they get followed up for up to 5 years at INCA. So, and then after 5 years of follow-up, patients with no evidence of disease recurrence are then discharged, okay? So, for each HIV-infected patient with cervical cancer, we identified up to 4 HIV-uninfected counterparts. And these two groups have been matched very closely on histologic subtype of cancer, and that's on a list of priority for matching. So first they were matched to histologic subtype of cancer, if it is squamous cell carcinoma or adenocarcinoma, and then they were followed up for clinical staging, which is of course very important, and then to cancer treatment, the type of treatment they received for their cancer, and then to age, with plus or minus 5-year interval, and at last they were, if possible, also matched to calendar year of enrollment of registration at INCA. So women with diagnosed cervical cancer between these two dates were this number at Cancer Hospital 2, almost 9,000 women followed at an institution. About 5,500 were tested for HIV. The not tested, untested women were excluded from the analysis, of course. And out of the tested for HIV, we had 91 HIV positive, and the majority, remaining of HIV negative women. 4 cases were excluded because they had more than one type of cancers, other cancers in addition to cervical cancer, or HIV diagnosis was made outside of the clinic, and so they were excluded, and we ended up with 87 HIV positive women, for which we matched HIV negative controls with cervical cancer at the institution at 336 women. So using a structured form, data from The clinical charts in the electronic hospital database were abstracted regarding demographic characteristics, health behaviors, clinical stage, and treatment. Following initial treatment, patients' responses were categorized as complete response, persistent disease, or progression to disease. HIV-infected women were linked to the Ministry of Health HIV database to obtain CD4 counts measured at outside laboratories covered by the National Health Service, and this kind of linkage is very important in this kind of studies. And date of cause of death were ascertained through linking to the Ministry of Health vital status record, the SIM, the mortality records of the Brazilian Ministry of Health. So predictors of overall mortality and cancer-specific mortality were assessed using Cox models. And for analysis that consider all women, regardless of treatment, patients enter at the time of registration at INCA, so that was time point 0. For analysis restricted to patients treated with surgery or radiotherapy, women enter at the initiation of that treatment, so that was considered in these analyses the time point 0. And then unadjusted and adjusted hazard ratios were calculated for demographic and clinical characteristics, and hazard ratios associated with HIV infection adjusted for variables that were significant in the univariate models. So for assessing early outcomes of cancer, a Markov model was used, and women started in state ill with cervical cancer and then transition of that state into one of four mutually exclusive outcomes, either complete response, progression, early death from cancer, or early death from other than cancer, or stay ill with cervical cancer, okay? And tests were adjusted for cancer clinical stage. So that's our early outcome analysis. And the late outcome analysis, we looked at the risk of cancer relapse among women who had had a complete response to initial therapy, and followed up, started at 8 months after the completion of therapy. So that's the time when we say, okay, this woman is cured for her cancer, of her initial cancer. And of course, women that died or had persistence of cancer before that date were excluded from this analysis. So relapse was considered to occur if a patient had a relapse documented at INCA, or if she died from cervical cancer, which also implies that she relapsed for her cancer. And a Kaplan-Meier curve was constructed to estimate the proportion of relapse-free women, and Cox models, both unadjusted and adjusted for clinical staging, were used to measure the association between HIV and risk of cancer relapse. So a little bit of the results then. So this is the characteristics in the two groups, HIV infected and HIV uninfected, that we analyzed. So what you're going to see is that for most of these parameters, the two populations are very well matched because we did that right? So we matched based on these parameters. Age at registration, the average age at registration was about 42 years old in both groups. There was a predominance of squamous cell carcinoma, about over 92% in both groups. And about half, a little bit over half of the women had been diagnosed at late stage cancer stage, meaning stage 3 and 4A and 4B. So that's a problem that we see in our patients. They actually search for health care for their cancer when already at an advanced stage of the disease, just like it happens for HIV here in the country, unfortunately. And we see that, of course, also for both groups, since they were matched for that characteristic. We do have similar numbers for the type of cancer treatment that they received, of course, because they were also matched for this parameter. Actually, HIV-infected women were more likely to be single than the HIV uninfected group. So that's one difference. But we didn't mean to to match by that parameter. And also about 40 to 45% of these women had been former tobacco users or were current tobacco users, and tobacco use is also a risk factor for cervical cancer development. So among the HIV-infected women, about half of them had CD4 counts measured prior to cancer treatment. So that's the data that we could get from the HIV/AIDS department at the Brazilian Ministry of Health. And for those women with data, the median CD4 count closest to treatment, to cancer treatment, was about 260 cells per microliter CD4 counts. So that's the univariate associations with overall mortality and with cancer-specific mortality. And as we can see here, HIV-infected women had a higher hazard ratio for overall mortality, and including a 95% confidence interval above 1, which means it's significant, and a little bit more modest, let's say, cancer-specific mortality association, 1.22, but again, having this confidence interval that includes the 1. So we wouldn't say much about this, but definitely overall mortality is significant. As this clinical staging, of course, there is a very strong association between the clinical stage of cancer and overall mortality and cancer-specific mortality in a dose-dependent fashion, meaning the more advanced the cancer, the more likely these women is to die, right? Either in overall mortality or cancer-specific mortality rates. Squamous cell carcinoma has been associated with overall mortality and with cancer-specific mortality. And body mass, having a higher body mass index or higher education were actually protective factors against overall mortality and cancer-specific mortality. So you have hazard ratios below 1. And of course, not being a tobacco user is also a protective factor for against overall mortality or cancer-specific mortality. So among HIV-infected women, the availability of a CD4 count prior to cancer treatment was per se associated with lower overall mortality. So that's an interesting piece of data that we're going to discuss. And here you see the associations of HIV infection with overall mortality and cancer-specific mortality in all patients or patient subgroups. And as you can see here, for all patients adjusted for clinical stage, you have higher hazard ratios associated with HIV infection than for HIV uninfected counterparts. And also in patients treated with surgery, you have very high associations with HIV infection as to the overall and cancer-specific mortalities. The early outcomes that we found, that we measured in association with HIV infection were all non-significant. So you see the hazard ratios and the confidence intervals here. And we think then that early outcomes like response to for example, to the primary treatment or the initial progression to cancer or even early cancer-specific deaths, in those parameters, HIV infection did not play a significant role or difference to HIV uninfected counterparts. However, when we looked at late outcomes of the disease, and this is probably the most important piece of result in the study, is that relapse-free survival, when we look at relapse-free survival after an initial fully successful treatment, meaning that you cure these women, at least at the macroscopic level, of their cancer, and then you follow them up for 5 years, HIV infection has been strongly associated with the relapse of these women or recurrence of the cancer in these women compared to HIV uninfected women. So you have here the hazard ratios, 2.84, and when you adjust for cancer staging at the diagnosis, this becomes even more significant. So HIV infected women had 3.6 times more likely to recur for their cervical cancer than HIV uninfected women, even if you adjust for all the parameters and after an initial complete response to cancer treatment. Okay? So this is the kind of data that comes out of the follow-up, very close follow-up that is only available at certain institutions. So Brazil is unique among countries in facing some of the major public health challenges in developing countries, right? Including a substantial burden of cervical cancer, which is typical of developing countries, but with the availability of resources that allow for centers of excellence in cancer care like INCA. So that makes it a unique setting for studying this kind of effects. Overall mortality was significantly higher among HIV-infected women than uninfected counterparts, but these differences in cancer-specific outcomes were much more modest, as I showed you, and neither was significantly different when adjusted for multiple variables in multivariate analysis. AIDS, as you know, AIDS is an important cause of mortality among HIV-infected people with cancer, and I showed you data about the association of HIV infection in the United States. At INCA, this difference between HIV-infected and uninfected women was much smaller, although significant, 1.24 of hazard ratio. And we think that higher overall mortality rates in Brazil probably due to higher advanced disease stage when women are diagnosed, at which women are diagnosed and start treatment, may account for these higher overall mortality rates, and these might obscure the HIV effect in this population. Overall mortality was lower in women with recorded CD4 counts. That's very interesting, suggesting that engagement in HIV care was positively associated with improved HIV disease control, and also likely with the adherence to both HIV and cancer care. So actually, women who adhere more strongly to their HIV follow-up and monitoring, they are less likely to die even from cancer when the cancer commits her. So there were few HIV-infected women with measured CD4 counts for assessing the impact of immune suppression or mortality on cancer outcomes, and that's really a drawback of the study. We think we would have missed CD4 counts for women who obtained HIV care outside the public system because we just have access to the unified public system. But such women are likely a minority in view of the high costs associated with HIV care and monitoring in the private practice, of course, and the resource limitations of the cohort studied herein. So probably most of the women that we are following at INCA also have their HIV care being taken through the public health system. But we only got about half of the women for which CD4 data was available. Early cancer-specific outcomes were similar in the HIV-infected and uninfected women treated at INCA, and HIV infection was not associated with an increased risk of progression or cancer-specific death or with a decrease in complete response to treatment. These results suggest that HIV infection does not negatively affect initial control of cancer achieved with standard treatment approaches. However, strikingly different, HIV-infected women are at a greatly elevated risk for adverse late cervical cancer outcomes. HIV-infected women were more than a threefold increased risk of cancer relapse compared to HIV-uninfected counterparts, even when adjusted for cancer staging at diagnosis. So, with, of course, an intact immune system plays an important role in long-term control of microscopic foci of cancer, which likely remain present in some patients with a complete response to initial therapy. So that's our current hypothesis. So even when you have a woman that is, that is considered cured for her cervical cancer at the initial stage, there might be some microscopic foci, like some residual cells that on an immune-competent host, these cells are eliminated by the immune system, but when you have an immune suppression mediated by HIV infection or, for example, in transplanted patients by medications, this impaired immune system might not be able to control these residual cancer cells, and that would explain the relapse after some years. So there are additional lines of evidence that support our hypothesis. Firstly, patients who have had an apparent complete response to cancer treatment, even who have been considered disease-free for a number of years, can experience an unexpected relapse following immunosuppression administered for solid organ transplantation. For example, the U.S. is very good also at linking solid organ transplant registries to HIV AIDS databases, and that's something that had been seen there. And also recently introduced therapies that target immune checkpoint molecules on surface of tumor cells and lymphocytes, for example, CTLA4, PD-1, PD-L1. They are very effective at activating an anti-tumor immune response and lead to improved outcomes for patients with a wide range of cancers. So these are evidence that support our hypotheses. So the strengths of this study: you got a large number of HIV and positive and negative patients from a single center, allowing robust comparison of these two groups, which is more difficult to ascertain in multicentric studies, okay? HIV-infected and uninfected patients were well matched on most characteristics, and staging evaluation and cancer care for both groups were driven by standardized protocols that met international guidelines. So that's another advantage of working with populations from a single center in which all these standardization is common and is feasible. Of course, there are limitations to these, to our studies. Small number of outcomes, especially when the analysis was restricted according to stage, treatment, or follow-up intervals. And it's likely that some HIV-infected patients who were known to be HIV-infected at the time of presentation to INCA were missed, since those women may not have been tested again for HIV in the institution. So we might have lost several of these cases. So in conclusions, HIV-infected women can be treated effectively for cervical cancer with largely similar cancer outcomes to HIV uninfected women. Among women who have had a complete response to initial therapy for cervical cancer, HIV infection was associated with a substantially elevated risk of cancer relapse. Additional research is needed to better understand the contribution of immune control in preventing relapse among cancer patients with initial response to treatment, and HIV-positive women with complete primary cancer treatment response should be followed up at more frequent intervals for early cancer relapse diagnosis in case it occurs. So as perspectives in this, our first study on the role of HIV infection in cancer outcomes, of course we want to reproduce cancer-specific analysis for other malignancies that are seen at INCA, for example, lymphomas, anal cancer, etc. We also would like, and that's work we are currently doing, to link the INCA patient electronic databases to HIV/AIDS database at the Brazilian Ministry of Health, with the CD4 and HIV viral load databases, with antiretroviral medications dispensation, and also with the mortality databases, and of course The ultimate goal is to link the major state and citywide cancer population-based registries to the HIV/AIDS database, something that has already been achieved in the US, but not here in Brazil. So I would like to finish by thanking people involved in this initial work. So at Brazil, at INCA, at the program of oncovirology, Mariana Ferreira, it's a master student of Esmeralda Soares that performed most of these analysis, most of actually the data collection and patient matching and patient selection. The program, people from the program of clinical epidemiology at INCA, Anke Bergman and Luis Claudio Tuller, who did most of the initial statistical analysis and hazard ratio calculations. People from the Hospital Cancer 2, the gynecological unit at INCA, Claudia Bessa Chaves, and the direction of the hospital. They're the clinical counterparts of the study. People from the information technology at INCA, Antonio Gonçalves, who provided us with all the electronic data sets that started the study to build up the database. And of course, our partners at the US National Cancer Institute, at the Division of Cancer Genetics and Epidemiology, Anna Coghill, Ruth Pfeiffer, and Eric Engels. Eric Engel is the PI guy on that initiative, and is the PI on the HIV cancer match studies linking the registries in the United States, as I've shown you. So with that, I would like to thank you for your attention, and I'm open for questions.